Labels, misconceptions, NHS remains a blessing. Created in 1948, we want it to remain great. A podcast where we share our stories, explore solutions in all their glories. They say it's broken, but it's not done. With your hosts Val, Barrett, and Dr. Jeremy Anderson.
Welcome to Stories, Labels and Misconceptions with Val Barrett.
I'm Dr. Jeremy Anderson.
Welcome to the final chapter in our Health Inequalities series, Episode 6, Common Sense Solutions. This is mine and Dr. Jeremy's own common sense solutions. So we've walked through definitions, causes, consequences, and decades of reports. And now it's time to ask, what can we do right now that would make a real difference? Practical actions that break the cycle. In this first part, we're looking back to move forward. So let's rewind. Let's look very quickly. In episode 1, we asked, what are health inequalities?
Health inequalities. No one's health is exactly the same. We know that. But when we talk about health inequalities, we're specifically talking about the inequalities are systematic and preventable and unfair. So we're talking about differences related to things like income, ethnicity, gender, geography, like where people live, and education. And these create differences in health outcomes. So these are systematic things that we could change if we wanted to, and that shape everything from life expectancy to quality of care.
Episode 2 tackled the social determinants of health.
Yeah, these are looking at, so not just the kind of the healthcare we receive that is just going to hospital or something, but rather things like housing, education, employment.
Bad housing. That
and
can impact on your health.
Yeah, we've talked about the impact of housing, damp and mold, impacting your physical health, employment, the environment you live in, exposure to things that cause ill health.
A lack of access.
Exactly. These have an impact on people's physical and mental health.
Okay. In episode 3, we asked, who gets left behind?
We're looking at who gets most affected by these inequalities, because these specific groups, it's not that there's something inherent about the group, but these factors affect different groups differently. Specifically, ethnicities, different ethnic groups get left behind more than others.
Traveling communities?
Absolutely. Yeah. We're talking about structural racism, structural inequalities, systematic barriers keeping people down.
Yeah. And people with disabilities. And also we talked about class.
Absolutely. That is an overarching element. All of these specific groups are getting left behind. When we talk about class, we're talking about income. These groups are getting left behind in terms of low income.
Yeah.
And that's exacerbating everything. I think that does point to a solution, because it's not about the amount of melanin in your skin or the language you speak that's resulting in these inequalities, but it's really about the amount of income you have.
Yeah. In episode 4, we looked at the long line and the ever-growing line of reports after reports.
Yes, we love to discuss a report in this podcast.
Because this country likes nothing but to produce reports.
Yes, we looked at 40 years of reports, all saying the same thing.
Yes.
Health inequality is real, it's unjust, it's rooted in social structures, and we need to do something about it. But every time something will get done, we get a change of government and so they bury a report, or a government says they want to do something, but then there's some sort of economic calamity that means that we can't.
But the main thing for me with these reports, we talked about 3 main ones. The Black Report, the Eggleston Report, and the Monmouth Review, ED2, 2010 and 2020. Even though the report still said the same things, inequalities, we know it exacerbated after the Black Report was done. So we know that there was another report, I think it was called the social divide. So,
Yes.
and we know the Black report, nothing was done. That was under Thatcher's government. But then what I don't like about these reports, it's all well and good having the reports and data in front of you, but there's no commitment to deliver on these recommendations. Unless they are mandatory, I don't see the point. If you live in a certain postcode, you have less access to services, or there's more obesity or diabetes, and then nobody actions that report. We do a lot of talking, we do a lot of writing, but we don't do a lot of action taking. And that's the bit that I do not like, which we will talk about in our common sense. So the last episode last week, that brought us up to date. The Lord Darcy report of 2024.
Yes.
That gave us the harshest diagnosis yet. As we said, we are flatlining. That's the terminology that we use. The avalanche is there, and we're trying to shovel the snow, and we've still got an avalanche. So do you want to say a bit about that?
Yes. Yes. This recent report by Lord Darcy is the one the current government is trying to implement some of the things that he's recommending.
Yeah.
And so talking about needing to rejuvenate the NHS workforce and make a number of different changes. They've already abolished NHS England, and they're folding that into the Department of Health. And they most recently, this announcement of community health hubs, which is one of the recommendations about moving patients out of large hospital centers that gobble up all the resources and more giving people healthcare more directly into their community, which is going to be better. So I think this brings us up to date, although not trying to get too political, but
I'm
I
waiting
think
for
it's
the next report.
the next, yeah,
wait on
not meaning to get too political, but the current government is announcing things and they can't seem to get it across the line.
I have faith in this health minister, but it's going to take government, local authorities, it's going to take us all to actually implement these things. We also have responsibilities for our health. Instead of shoving down KFC every night, I should eat better.
Yeah.
There's a lot I could do better. I don't expect the government to nanny me. I don't expect them to come round and say, look, here's a bowl of fruit and here's a salad. So at times there's going to be a lot of education. I'm glad they're going to be talking to supermarkets because that needs to change. But we'll get into that. We've heard the evidence, seen the patterns. The time for awareness has passed. No more reports. Now it's time for action. The next part, we're looking at common sense solutions. This is something I like. Make health inequality everyone's business.
Sure.
Because if we said, in the social determinants of health, it crosses everything: income, housing, education, transport, access to services. So it should be just like I said before, there should be a stick of rock. You cut it open and it should say health inequalities going through that stick of rock. It should be everyone's concern. Something seamless from each department in government. It's not an isolated issue within social care and health department. That is what I'm trying to say.
Yeah.
So even if you don't have a health condition, you could be suffering from health inequalities if your housing is bad.
Exactly.
Damp, mold. People think, oh, it's housing. No, yes, it's a housing issue, but it's also a health issue. If we start from that point,
I think
could make a difference.
Yeah, I've mentioned it a couple of times, but I think one of the solutions has to be and I don't know exactly how this would be done, but thinking out loud here, I think we have to have the idea that we shouldn't be keeping budgets completely separate from each other. We need to recognize that if we don't spend money on one thing, we end up spending it on another.
Haven't you noticed that when one budget goes, eventually it always ends up in the NHS? Haven't you noticed that? The end result is you don't fix housing, person gets sick, NHS. If you're working 0 hours contract, you haven't got time, you can't afford to take time off to see your doctor. You could have anything. You could have cancer, let's say, and you don't go until you're really ill. Any of these things eventually works its way up into the NHS.
Into the NHS.
And that is the number one budget that gets bigger and bigger.
Yeah, I think that's right. So I think at the level of government, we need to recognize that separate budgets and departments end up trickling into the same budget.
Yeah.
The way we allocate resources for these disparate things, schooling, or how we fund things according to local property prices, meaning that some boroughs get resources or get services and some don't because they're so-called deprived boroughs, rather than individual communities getting services based on property prices, but pooling everything together and giving everyone the same level of service, regardless of where you live, might be one solution. So I think there is a budgeting kind of solution to some of these problems.
Every policy, not just health, should be evaluated for its impact on inequality. In education, there should be a team that looks at the impact on health inequality. There should be a core team in every single department. It's like we said, if each department are cutting, like they like to cut, eventually that cut deprives a certain group.
Yeah.
And eventually, when it gets worse, 9 times out of 10, that cost goes straight to the NHS. We already know social care isn't working. Until that gets working, everything goes to the NHS until we get more GPs, where people can access their GPs. People are going to go into A&E more, which is a bigger cost. People are going to take up a bed, which is a bigger cost. If your housing is bad, you're staying longer. If you're elderly, you can't take care of yourself, you're staying in a hospital bed even longer. So the cost always is in the NHS.
Yeah, I think that's a good idea, Val. In the same way we do environmental assessments, like if you want to build a building or a transportation project, we do an environmental assessment. What's the impact on the environment of this thing? We could do a health equality or inequality impact assessment for any project. I think that's a good idea.
I hate, as we talked before, the words that we use, which you are now becoming accustomed to.
Yes.
Stop using the word deprived. I really do. Use words where you want healthier communities. Stop saying deprived. When you keep saying that, it's always going to become that.
What do you mean by that, Val? When you say if you use a word, it becomes that. A self-fulfilling prophecy.
We already know there's a lack of certain things there, which makes that area more deprived. But if you keep telling people where they lived is deprived, you don't have this, you don't have that. Okay, I'll take it back a bit. When I was growing up, I didn't know my life wasn't as good as somebody else's. I didn't know that.
Okay.
I was just living my life. No. It did bother me.
I gave an example of a patient looking for mental health care in the community, told they had a 2-year wait. I said, why do I have to wait so long? And the person said, it's a deprived borough. And that's a description, but it's not quite the explanation.
It's not.
It's just...
It's a cop-out.
Yes, I know I'm deprived, but why is... But the question she was asking, like she was saying she knows she lives in this borough, but why is it deprived? Why are we not funded?
Exactly, because those are the very areas we talked about. I was involved in New Deals for Communities back in 2001. It's all right using the word deprived, but if you're still using that word 20 odd years later, then you ain't done nothing. The dial hasn't moved. And these areas shouldn't still be deprived. If these areas have been labelled deprived for so long, why haven't they moved on? That's exactly where the mental health services should be. That's exactly where the GPs should be, and more of them. Exactly where more social care and health should be, to take it from an area so-called deprived to an area that is healthier or on par with other areas. We shouldn't have a system where inequality is so wide. That is what I'm saying. It shouldn't be so wide. I admit that. Yesterday, I had to book for a pneumococcal vaccination. I booked it. Then I got a call an hour later from the doctor saying, "You've booked this. Are you still caring for your son?" "Yes." "I'll extend the appointment so we can talk about that and do an assessment." And I thought, okay, simple thing.
A visceral reaction to the word. But would it be fair to say that the real problem is when the term we use to describe something, whatever that term is, we want people to respond by saying that's where the resources need to go, rather than as an excuse for can't do anything.
Okay, I'll give you an example.
Isn't that the problem?
I give you the opposite coin to that.
Okay.
Now I live in Kensington and Chelsea.
Yes.
As soon as you tell people
Super snooty neighborhood.
Not snooty, get lost. As soon as I say where I live, I could be living in Wheelie Bin, love, everything. But yet there are two parts to this borough. You've got that long road, Labrador Grove. One end is on, as they say, on the poverty scale, and the other end, leading up to Holland Park, is wealthy. But yet, the overall riding factor in people's minds is that we're okay. Do you see what I'm saying? Just because we live in this borough, people don't think there are pockets of neighbourhoods that are deprived. No, they bypass that and say, we're all rich. No, we're not bloody rich. But then you'll mention an area in the north of England. People think the north is really bad. And you'll mention an estate or an area known for being deprived. But there'll be people there working. People there with good jobs.
Oh, of course.
Yet we label it all that. And don't think there might be a pocket in that neighbourhood doing okay. Do you see? People think we don't need as much because we're all okay in K and C when we're not. The house prices in this borough don't reflect the low income in certain areas. The house prices are high, but yet there's a lot of poverty as well as a lot of wealth. But in people's minds, the wealth overrides the poverty. But then that's not fair. So it's what people think of an area when you mention it. You mention certain parts of North London. Okay, Chipping Norton. They think, ooh, people there, they've got money. Now, I've never been there. There might be a little area where people are not doing as well. But we tend to do that because we label. We talk about it before. Labels. It doesn't help. We've got to get to the stage where it's deprived now, but that's not where we want it to be. If you keep saying it is, it's going to stay that way. Sticks in people's minds. People might not invest in that area. People might not set up business there that indicate it's deprived. You want an area like that to thrive. You want to bring people in. You want to bring housing in. You want to bring in businesses, resources. You want to make it healthier. You want to make it more attractive. But the more you keep saying it's deprived, no bugger's going to want to go there.
Yeah, that's one of the solutions we talked about. Give resources to where they're needed most.
Yes.
If you have a community that needs resources, rather than just using that label to shrug our shoulders and say, well, that's the way it always is, that should be a magnet for resources.
That's for one, make health inequalities everyone's business. If it's not just about policy, not just about health policy, we want everywhere to evaluate its impact on inequality. We want to embed equity. Is it equity?
Equity is similar to equality, but rather than treating everybody equal, it's recognizing some are starting out further ahead. We want to do is give resources, again, where they're needed, so that we achieve equality.
We want to embed equity in everything: transport, planning, employment, education. They failed on transport when HS2 started in London as usual. They said the North is deprived. God forbid they start a major project in the North. And then it comes down to, we can't afford it anymore, and it doesn't reach the capital. Do you see what I mean? And that's so sad. It's like the North is always shortchanged.
Yeah, that was another solution that we proposed is, why don't we do some things backwards? That is, if we're going to start a project, start it in the North, see whether we complete it then. If we're going to make another report, rather than spending a whole lot of time talking about the problems, put the solutions up front.
I know, I hate problems. Let's move on. Episode 2, we looked at social determinants. So invest in the social determinants. Like we said before, housing seems to be getting worse. Social housing, really bad. Too many deaths. Arab law came into force, I think it was October last year. We'll see how that is going, but as far as I know, it ain't going very well, because since then another child has died. I think it was due to housing. So we know what happened after Grenfell. You would have thought around the clock that would have been taken down cladding up and down the land. No such bloody thing. You know, so it's, you look at what's the right thing for them to do. Take a hit on the money and put people's lives first. Cost to take it down, people's lives. They have to make that choice. They've already made the choice, because after all these years, the cladding is still up. That tells you all you need to know. So we know affordable housing, people need secure jobs. I think they talked about that just recently, getting rid of 0 hours contract. Good luck with that. I don't know how that's going to work, because you look at places like, is it Deliveroo? Places like that. Don't know how that is going to work. As I said, there's always a wish list, but where's the meat on the bones? How is it going to happen? Do you bring in these companies? Do you say, look, this is a policy we like. How can we work with you to make this work? Instead of writing off the hoof and thinking, this is what we'd like. Nobody wants to know one day they've got work, next day they haven't, because you can't budget. 1 month you've got money, next month you haven't. Eating or not eating is not an option. Paying your bill, it's not an option. You know, not like whether you want to implement a report or not. Pills is not an option. So that, I don't know how they're going to sort that out. Quality education, it's like everything's going down the tube. They need to sort that out, whether it's special needs education. I had to fight for that. Thank God he's 31 now. They've just got to think about prevention, not just cure. My doctor phoned me back. Let's talk to her a bit more, find out what she needs help with. Prevention. That's all it is. Prevention. Before I could get worse. Do you see what I mean? And I remember a call when I was shopping and the GP called me
Yeah.
And I said, I've got to stop. I'm not breathing right. And he said, what's going on? I said, my neck and things like that. But because I have lung disease, we thought it was my lungs. So I went in for those. We later found out it was my heart. Do you see what I mean?
Yeah.
And this is the thing, it's about prevention. It's about trying to catch something early. We MOT our cars. We have insurance on our homes. God forbid our laptops, phones, or in your case, your dog gets stolen.
No, my dog will never get stolen.
Oh, Jeremy.
Never leave him alone.
So what I'm trying to say is we have insurance on everything.
Yeah.
When was the last time you went to see your doctor? When's the last time you had a check? Check your blood pressure, your saturations.
The last time I went to the doctor was about 6 months ago for a health check. I donated blood a little while ago, so I didn't get my saturations checked.
Okay.
They do checks and things. And the whole idea of prevention should resonate with policymakers because prevention saves money.
Exactly.
The sooner you catch something, the cheaper it is to fix.
So even if we brought like the little SAT monitors you can buy.
Yeah.
If everyone got taught to use one of those at home, their blood pressure monitor, that can help.
Yeah.
And find a way where we talked before about AI, which they are investing in, where we can input our numbers. If something alerts wherever it goes to, then they say, go to X, Y, Z. We've got to look at things people can do at home for ourselves. I'm always doing temperatures at home.
Yes, there's really great stuff right now with all these wearables, electronics that monitor parameters like blood pressure and heart rate and things, oxygen saturations. Essentially, what's really good about that is people can do biofeedback with themselves. So biofeedback is just basically taking one of these parameters and presenting it to a person in a way that you can see. You can't feel your blood pressure, but if you have a beat-to-beat measurement of your heart rate or your blood pressure that you can see on a screen, well, now you have a certain level of control because there's things you can do to lower your blood pressure. If you're doing relaxation, you will lower your blood pressure. And if you can see your success on the screen, then you know you're doing it right.
Okay.
So this kind of information can really help people to do things to help make themselves healthier.
But also, I read somewhere there are community well-being link workers, something like that. So especially if there's someone not able to take their own blood pressure, SATs, temperature, there should be somebody to visit them at home. We've got to think prevention, not just cure. What can we do to help people help themselves at home? Okay.
Exactly.
So let's look at what we talked about episode 3. It's about protect the most marginalized when we looked at these groups. So in those groups, we had ethnic minorities, we've got disabled people, people living in poverty, which is not about colour, low income. Those groups could be the protected characteristics.
Yes.
Within health. We need to fund culturally competent care. What does that mean to you?
What does it mean to me?
I'll tell you this story. When I look online, my son has just gone through a rash all over his body. You can always find what it looks like on a white body. Very few of our colour. In some cases, it will take somebody from your own culture to see things differently. You see what I mean? Whether it's someone that works with the trans community, ethnic minorities, the disabled community, sometimes it takes that specialist better. I don't know, in some cases.
I think what we mean by that, by culturally competent, it just means people who are familiar and understand a group of people intimately. You just have a better understanding. For example, doing a workshop on healthy eating.
Yeah.
but you're recommending everyone go to Whole Foods and buy fancy, expensive stuff. Not as effective. You need to know where people are at.
I remember we did that where I used to live. This woman told
Yeah.
Jamaicans, stop using coconut cream in your rice and peas and chicken. Really?
That's not going to go well.
That ain't going to happen. Because culturally, whether you're Greek and you traditionally cook Greek food, you traditionally cook Italian food, Spanish food, Caribbean, everyone's got a way of cooking. And it takes another person, whether it's a language barrier. I have a neighbor who's Spanish. Sometimes I find it hard to understand him, and he finds it hard to understand me. It's easier for him to get it when it's spoken in his first language.
Right.
It's a lot easier. So when I think we need culturally, it's not just about colour, that language barrier and understanding how that culture does things differently.
Yeah. And so understanding, obviously giving people information that they can accept, but also giving it to them in a way that they can understand, right?
We're going to tackle systemic racism in health systems, where Streeting is doing another, I don't know if it's another report or review, looking at maternity care for Black women.
Another report.
Come on.
We'll have to make an addendum and add a report to our series.
He did, because I made a comment. I thought, another one, make services truly accessible for disabled people. I remember I watched this award show. They knew they were giving an award to somebody in a wheelchair.
Yeah.
And they never made it accessible for the person to get on stage to get their award.
The person has to stay in the audience.
They moved up and then couldn't get on stage. That tells you a lot. Tells you a lot. And as well, what I noticed, I know we're going off topic, talking about disability. Do you know what else I don't like? After the Olympics, we have the Olympics. Why is it they have a party before the Olympics is finished? So they have a party to celebrate the Olympians that took part in the Olympics in Great Britain before the Paralympics is finished. Don't you think all Olympians? Do you see what I mean? I've always found that strange. I think we're supposed to be inclusive. Talk about an inclusive society, but he treated them differently. I was watching a show the other day, and I can't remember his name, the guy out of JLS, one of the singers, he's doing something to help young carers. We talk a lot about carers, but a young carer that can't get to school because the person they're caring for needs them at home, or they can't do an after-school club because they're going to rush home to cook. They can't go out and play with their peers because they've got to go home and cook. They're doing what adults do. When you look at the age, we are children for a very short time. Up to 16?
Yes.
From 16, we're basically adults. So our childhood window is extremely short. Time is spent caring and not enjoying the joys of childhood has to offer because there's no support for you. You're falling behind at school. Where's the hope for that person? Even when they become an adult. It says a lot when we have the 7th richest country in the world where we've got young carers.
Yeah.
Gone are the days where we sent them up the chimney. They shouldn't be doing that.
Yeah.
Not the way they're doing it now. No, they need something more around that. I don't know if they do, but they need to do more. Okay, let's look at episode 4. Stop commissioning reports.
Yes.
Stop writing reports. Stop it. And start committing. All in. Full commitment.
Yeah.
If you're going to do it right, go hard or go home.
Yeah.
But there's no point in me reading a report for, they're going to do this. And then I get to the end. One report said it's not going to be legislated, meaning they can either do or they don't.
Right. The point is, we've been looking at these reports for 40 years. Yeah.
Set up legally binding health inequality targets that are timeless and accountability, whichever government is in. That's why I keep saying, Dr. Sherry, now you understand what I keep saying. Take all this out of government control, and whoever's in power, they can't mess with this. There has to be something that says, okay, this is the last 10-year plan. And we'll see how it goes for 10 years. Because a 10-year plan is going to take 10 years. That's how long it's going to take. Yes, you're going to see things happen probably in the first 3 years. I haven't seen the plan, so I don't know what the milestones are and blah, blah, blah. But it's going to take 10 years. I don't want another government to come in. I don't want another government to come in and scrap it. We're looking at another election in 4 years. So I don't want it scrapped after 5. That's if Labour make it through the 5 years. I don't want it scrapped.
No.
After that. You want this to be the report that is fully committed. It's a very good report. It's at the crucial stage where we know the NHS is flatlining. And it's like it's on its last legs. Yeah. And it's make or break. And I hate the handprints all over it. Empower public health leaders. Politicians commission the report. We're going to get public health leaders and social care to buy into this. Deliver on the implementation of the recommendations. Politicians now take a step back and empower those on the ground and leading the charge to make the difference, fiddle with it, because you don't work in the NHS day to day. Come to the dispatch box and make your announcements, update us. What now is the time to take a step back and allow this 10-year plan to go full 10 years.
I think it's important because a lot of these changes, they're not easy fixes, right? So
no, they're not.
If we think about what do we need to do to fix the workforce problem that we've got, so it takes a long time to train people to do these jobs. It's not something you can do in a year or two. Yeah.
Episode 5, rebuild trust in the system.
We need to fix our workforce because we've got shortages. That's not something we can fix quickly.
They just made a big boo-boo with the social care visas.
Suspect there's another.
Soon to be another one. I can feel it.
But whether they do or don't, it takes a long time to train people to do these jobs because they're highly specialist.
Exactly. So you'd think that they would wait, train people before they say we're not doing anything. And I think one of the issues that Labour has, they're too concerned with what reform are going to do or what reform is saying. If they keep doing that, they're going to be making a lot of mistakes, doing a lot of U-turns. Labour's best when it's Labour. And they've got to remember that. They've got to stay true to who they are, to their values, their principles, and not chasing reform. They are not reform. And for them to do the visa thing without what's going to replace that? Nothing. Social care has already got a big gap already in its workforce, and they do that. It makes no sense whatsoever at this time. At this time, it makes no sense when you have no plan B. They're hoping by some miracle that the British workforce suddenly apply for these jobs. That's going to take a while. So we
Yeah.
talked about that before. That's going to take a while. And I think it's one of the facts that they think working in social care homes and that is a low-skilled job, that any old jackal Jill can do it. And I think that's one of the mistakes they've got to change that. We talked about that before. Get a register like they've got in Scotland and Wales.
Raise the status of the profession.
Exactly. Upskill it. Let the staff know that there's somewhere that they can progress to, probably to become nurses. That can be the stepping stone, perhaps.
Yeah.
They've got to think of different ways of training nurses as well. That can be a stepping stone into nursing. Working in a care home and studying at the same time. I'm just thinking out loud. But that could be another route. We're short of nurses. We need more nurses. Or even doctors. Wouldn't it be good if you actually had a trained doctor that started off working in care homes?
Sure.
That's experience.
I was thinking about making these jobs more attractive to the local workforce, right? Because a lot of these things these are necessary jobs, but they're jobs that are not attractive to people. So there's a lot of people who don't want to do the jobs. You're not going to fix the workforce problem until those jobs are attractive
and well respected and appreciated by the government.
Precisely.
So, and this is especially in deprived areas. I read GPs are fleeing deprived areas, perhaps because there's not enough of them, they're overworked. They need to look at that as well.
Yeah.
And we talked about this before. Shift focus from hospitals. The hospitals should be the end result. Our aim should be, let's keep them out, and you only go in when you really need it, which of course we do. But like we said before, when it comes to mental health, that's no place. A&E is no place for someone that is having a mental health episode. No place for that. It needs to be community-based, person-centered care. How that works, I don't know. I don't work in government.
That's consistent with what the government is doing with these community health hubs.
Yes.
I think that is part of the process. And I think there's other initiatives out there that are trying to address people's health needs in the community, particularly if they're lost to follow-up because they don't want to come into large hospital centers. That's great.
Yeah. Okay, let's look at the last segment here. What's standing in the way? Things that we've talked about aren't radical ideas. We know some are happening now, but if they're not, why haven't they?
One thing we talked about is political leaders, the people assigning budgets and making decisions, are concerned about things. Right now, it's concern about reform. Anytime you're trying to go somewhere and you're worried about the concerns of the day, you end up zigzagging back and forth. And if you knew where you want to go and you make a straight line for that goal, regardless of what's happening, you'd get there quicker.
We also talked about political short-termism.
That's really what I'm referring to.
My number one thing. Take health inequalities out of politicians' hands.
Yeah.
Labour, Conservative, Reform, or a new party is in power. It doesn't matter. There's a blueprint that will always stay and be worked on, irrelevant who's in power. Budget cuts, when they talk about reform, we're going to reform the system. It's not reform. You're cutting. Look what happened the other day with DWP.
PIP and universal credit. These cuts are designed to save money. We do have serious
But why start with PIP? A lot of disabled people get PIP. They work. People forget they work. Job seekers, people should be seeking job. They are not working. Why did they start with PIP?
With disabled.
Why? These are the people that need it to stay in work.
Precisely.
At the end of the day, they thought they'd pick an easy target. Did they get that wrong? They ain't going to save nothing. If anything, it's going to cost.
No.
They're not saving nothing at all. And it was an embarrassment. It was just awful. And it's like everything they wanted to rush through. Why would they vote this through and the review by Stephen Timms, the disability minister, hasn't even been published? It's like walking around with a brolly and it's sun shining. Oh, it might rain. Just ridiculous. Wait till the review or work on it more. They knew people didn't like it. They knew there was a rebellion. There's no working with. There's, this is what we're going to do. And then here, vote on this. Apparently what I read, or I heard, he hadn't even met the backbenchers. Because usually they'll come in small groups to meet the new prime minister. He ain't done that. That tells you a lot. Anything you want to do, he should know this. Take people with you. If you don't take them with you, those same people behind you are going to go against you. And that is exactly what happened. It managed to get through, but with concessions.
Yeah.
So he practically chopped off his limbs. What was the point? So you need a system that listens. We've got a system that listens to data, but not to people. They need to work with groups more, whether it's disability groups, organisations that work with disability groups, people that live in social housing, and whatever. There needs to be more centred around, because they keep talking about people-centred care.
Yes.
Do you see what I mean? But when they're looking at their quote-unquote reform, it's not reform, it's cuts.
At numbers and data, if we look at health inequalities and treat them as a technical budget problem, we're missing the point. It comes down to a moral choice. What kind of society do we want?
A healthier one.
If we want a healthier one.
Equal one.
Or
a
at least,
fairer one.
Yeah. Right?
People are not stupid. They know there are going to be rich people.
Yeah, sure.
But they want people to pay their fair share of tax. If they want to leave the country, stop threatening the government by saying, if you raise taxes and we're going to leave, sod off then.
I think it's fair to say that people want conflicting things. People like to get things. But if they really think about it, they want everyone to get something.
Oh, yeah, of course.
Yes, I like to get things, but I also want to live in a world where everybody gets things too. It's a moral choice.
Yeah, it is. Let's look at a call to action.
Okay.
If you work in policy, push for cross-government accountability. I don't think there's enough accountability. There isn't. You always hear of people going to court over whether it's somebody has died in their housing or let be case or whatever it is. But there's no accountability, none at all. And it doesn't take anybody with a PhD to say that if you live in a house that is covered in damp and mould, the likelihood is it's going to affect your respiratory system when you're very young, you've got a condition, or you're very old. It's as simple as that. If you don't know that by now, as head of housing, you shouldn't be head of housing. You may not be able to move them to a decent home immediately. This is when hotels should be used.
Yes.
That's the bottom line.
For our listeners, if you're a health worker, it's always about pushing for better outcomes for patients and ourselves. I think that healthcare workers, rather than just following a checklist, just actually asking yourself, reflecting a bit and saying, what could I do better? What are the better outcomes I would like to see for my patients?
Yeah.
Yeah. If you're a healthcare worker, if you're not in a position to make changes, escalate to someone who is.
If you're a community organizer, keep building power where it matters most. Empower people more. We've got to. You've got to give them the resources that they need. You've got to give them access. You've got to give them information, everything that they need to empower themselves to make better decisions. Some people just need help and support. We are adults. And whether that adult lives in an area that you label deprived or lives in an area that's not labeled deprived, you treat people different depending on where they live as well. So even though where I live, I still need to be empowered with certain things. But okay. But the people that you need to really empower, those at the other end of the scale. Because everybody wants a better life. I don't believe anybody wakes up every day and say, I want a shit life. That's ridiculous. I want to live in a deprived area. I want my housing to be bad. I want to live in poverty. They don't. Circumstances beyond their control has led them to be living the way that they live. It is not a choice. Some people want to work. I heard on the news, this young woman, she left university, applied for hundreds and hundreds of jobs. With a graduate, can't get a job. How do you expect someone at the other end of the scale that's probably been raising their children for years, been out the job market for years, how do you expect them to do it? Just because it's been easy for a certain group of people, nepotism, and cliques in government, things like that works for them. In the real world, people at the other end, people like me, probably like you, we don't have a friend that runs X, Y, Z that can just give us a job.
No, I was involved.
Real hard work to get a job.
I was involved in a hiring process recently. There were over 50 applicants. Even if you're in the top 10, you still only have a 10% chance of getting the job.
Exactly. That's where inequality comes in. I mean, there's inequality in everything.
The job market is tough in some areas.
Okay. And if none of these work, if you're none of those things we mention, I can't stress it enough. I would never tell anybody how to vote, but I would tell people to vote, volunteer, speak up. I started by getting involved in my local community when New Deals for Communities came in, when Blair was in power in 97, and they created these New Deals for Communities around 2001. I was involved in that. So you start off locally. Everyone's got something to offer. I don't want anyone speaking on behalf of me on my life. Only I know how it is. Whether through a podcast or local, I'm going to use my voice.
Yes.
Because it's one thing we all have. Another is to use it and let people hear you and respect what you say. Not all of us are going to be able to say it in a way that politicians or people that write policy speak. I don't speak like them. But before I was like, oh God, is it my place? No, you're damn right. It's my place. People have to learn to use their voices more. Yes, people will say, oh, I'm not voting. They don't care about us. If you don't vote, the data shows the ethnicity of the people that voted, the age group of the people that voted, the area, who they voted for.
Right. And so the more people who vote, the more valuable, the more attention those groups get.
Okay. So
presumably.
Because when we say health inequality, we're not just talking about statistics. We're talking about people's real lives, real losses, and the solutions. They are not out of reach. They just need courage and commitment. So that's the end of this episode. Dr. Jeremy's going away for, is it the next 3 weeks?
It'll be 10 days.
Missing 2 episodes.
Yes, I'm going to miss 2 episodes.
So miss me or the dog more? Oh, good. I don't know why I said that.
I think we know exactly who I miss the most. Yes.
Oh, Jeremy, really? I think the dog's going to be very upset. You're going to be missing me.
Junkie will be
I'm going to plow along without you.
Okay.
We hope you enjoyed today's episode. Let us know of your common sense solutions. Let us know what you think of what we've said. And follow us on Twitter, Instagram, and Facebook. And have a nice holiday. When you're away having a nice time, think of me back here slogging away.
Sweltering. Okay.
Thank you. Bye.
Thanks, Val. Bye-bye.
Bye.